go by. Cellophane flowers of yellow and green towering over our heads.
Oh, here it is. Okay, that's what I needed.
Aging skin disorders.
Thank you. Can everyone hear me? Okay, terrific. Yes, as she had mentioned, actually my background, I'm a nurse practitioner, and I'm also a certified wound ostomy and continence nurse, which basically means that I love anything related to wound and skin. That's really my passion. And that's one of the reasons why I was asked to come speak to you today, is just to kind of give you a little bit of an overview of some of the common geriatric derm issues that you will run into despite your practice areas, and also a little bit on pressure ulcers, since that's a really common problem, particularly in the long-term care environment. Now, just out of curiosity, how many of you routinely deal with patients that have any kind of wound or skin care issues on any regular basis? We have a few hands there. Great. So for some of you, this will hopefully be kind of a review or an overview, and maybe for some of you, a few interesting little pearls that you can take back to your practice areas. So with that in mind, we'll go ahead and get started. The objectives for today really pretty straightforward. We're going to talk about some of the implications of an aging population, especially with regards to wound and skin care issues. Talk a little bit about some of the common changes in the skin that occur with aging that, again, are probably something you're already familiar with. We're going to talk about some common benign and malignant findings in terms of skin conditions in the older adult, and a little bit about the management of pressure ulcers. So again, this is a lot of stuff. You're getting a little bit of a Reader's Digest version here, but hopefully it will be some good food for thought. I don't think that for any of you it's that this is news that our senior citizen population is growing at almost an exponential rate. We have the baby boomers, which in another 10 years will be reaching their Medicare retirement beneficiary age. And as you can well expect, that's going to put an incredible strain on our system. We have currently more than 33 million seniors that are over the age of 65, and by 2010, which is just a few years away, 40 million. And by 2030, 70 million. So as you can really appreciate, we're going to be having just an increasing number of challenges as healthcare providers in dealing with geriatric patients who have a variety of problems, including skin and wound care issues. The number of people over the age of 65, I thought this was really impressive, has increased 100% from the period of 1964 to 1994. That's pretty phenomenal. About 1 in 8 people are currently over the age of 65, and by 2050, 1 in 5 will be over the age of 65. Florida alone has currently about 19.6% senior citizens, and that's projected to go up within the next few years to 25%. So that's pretty dramatic if you think about it. And so the implications of that, as you can well expect, is that our seniors in general, as they start, again, as the baby boomers start to get into the retirement age, we're going to find that they're going to be a very well-educated, more financially solvent group of people and healthier. However, as I mentioned, this large increase in the number of elderly in general is really going to put a strain on our healthcare net. And then I think where we're really going to see the challenges come up is that with our oldest old, our patients that are in their 80s and upwards, are really going to have a lot of problems. They are going to be more likely to be poor, have financial issues, prone to medical problems, and have limited family support. And that's really going to be probably the biggest challenge that we face as healthcare providers of these folks. So what does it mean? Again, as our population ages, wound and skin care issues are going to continue to be a challenge for us. And I think it's important, too, to realize that providers in the acute care, home care, long-term care, clinic settings really need to be knowledgeable about some of these issues so that we can interact in a timely fashion and to provide the appropriate amount of care. And at least if it's something that maybe is not an area that we are necessarily experts in, but at least if we can identify a problem, then we can bring it to the interest of another clinician or coworker or physician or surgeon, if you will, or dentist, so that that particular issue can then be addressed and the patient can get the best outcomes. So a little bit about skin changes with age. Again, as you probably are well aware, as we get older, there are a significant number of things that change in our skin, most of which is not necessarily what we want to see, but unfortunately we don't have a lot of choice in the matter. The epidermis, we notice that there's a decreased number of melanocytes, which are the cells responsible for coloring and pigmentation. They decrease, and so we see variations in pigmentation in the older population. The Langerhans cells, which are responsible for delayed hypersensitivity reactions, decrease. We see that within the dermis itself, over the age of 65, there's an annual 1% decrease in the amount of collagen. And collagen, as you know, is very important because it provides the framework for our tissues and provides tensile strength. And as the collagen decreases, we see that then the skin becomes more lax and we're more prone to decreased elasticity and wrinkling. So we also see that the skin density decreases as well. One of the things that also happens is that there is atrophy of the subcutaneous tissue, particularly in the face and the extremities. So the face becomes a little bit leaner and more gaunt over time. The extremities might become more thin, but unfortunately then we see hypertrophy of the adipose tissue in particularly the hips and waists of women and the waists and stomach of men. So not necessarily something that we get excited about, but it is one of those natural processes that change with aging. And this is just showing you here just a cross-section of the skin, if you will. And obviously we know we've got our epidermal and dermal layers, and the dermal layer is really the active functional layer of the skin. And it is just absolutely replete with sweat glands, nerves, and microvasculature. And one of the other things that happens over time is that there's a gradual decline in the number of sweat glands, there's a gradual decline in the microvasculature and in the nerves. And this puts the elderly at much higher risk for problems with thermoregulation, that puts them at greater risk for problems with heat regulation, and also makes them more prone to sunburn. So these are things we need to keep in mind. The other thing too is, if you notice on this cross section, that there is actually in a healthy, normal adult, there is basically a very tight connection between what we call the epidermis and the dermis, and this is called the dermal epidermal junction. And if you look at this cross section, you can see that there are these little ridges. These are called ret ridges or ret pegs. And again, those of us who are not of advanced age, that epidermal dermal junction is nicely cemented together, and that helps to protect us against trauma and problems related to skin tears. Now in the very, very young, in infants for example, they don't have very well formed epidermal dermal junctions, and in the elderly, over time, this epidermal dermal junction becomes flattened, and so you don't have as great an adhesion between the epidermis and dermis, and this is one of the main reasons why we see problems with elderly developing skin tears. So just something for you to be aware of. And then of course, if you look at the other end of the spectrum with the the pediatric population, this is one of the reasons why newborns, neonates in particular, can be very prone to skin trauma and skin tears as well. So these are just some of the natural things that we see over time. And I think that, again, realizing that, again, should be something that underscores the importance of knowing these changes so that we can take some of the precautions that we need to protect our elderly from these types of problems in terms of trauma, pressure damage, and sun damage. So some of the common things that we're going to talk about today that you will see, and again, this is by no means inclusive, but this is just to kind of give you a little bit of a potpourri or an overview, if you will. We're going to talk about xerosis, which is basically a very nice cocktail party word for dry skin. Seborrheic dermatitis, which is again a very common problem that you'll see not only in the elderly but also in the adult population. Seborrheic Keratoses, which I think are very interesting and a very common finding that sometimes people get really upset about. Dermatophyte infections, yeasty beasties, fungus amongus kinds of things. The actinic keratoses, which are sometimes considered pre-malignant. The skin tears, which I've touched upon, and then we'll talk a little bit about the malignancies and the pressure ulcers. So this is a little bit of what we're going to be discussing. Now, xerosis. And I think probably some of you here can attest to the fact that sometimes when we are in a low humidity environment, especially in the middle of the winter, sometimes we can really be prone to problems with dry skin. And xerosis, or another technical term, erythema cracal, this is a very, very common problem. This is probably one of the most common dermatological conditions that we see in senior citizens. And basically what it is it's excessively dry skin. It's often associated with pruritus or itching, and so a lot of times when this happens, there's a tendency to want to scratch. And so a lot of times these folks will go ahead and scratch and dig at the skin, and then that sometimes can potentially cause a secondary infection. So one of the most important things with xerosis is prevention. And we see that the most common reason for this is then again as folks get older, and in people in general, it can be basically an overproduction or overmaturation of keratinocytes. And keratinocytes are basically the little, again, the little skin cells that form when we have an open wound, and that open wound heals. The keratinocytes are that's that friable new layer of cells that will come in to cover up a wound. Well, in some situations, some folks are prone to an overproduction, and then these keratinocytes tend to want to clump together, and so it creates kind of a scaling and a fissuring and an itching, and results in this particular problem that you see here. So a common problem, but it has a very easy cause or a very easy treatment, and that basically is to moisturize the skin. So the treatment of choice typically with xerosis is to apply an emollient of some sort. Commonly, ammonium lactate, which is your lachydrin, is a wonderful option for treating this type of problem. Your urea-based products like your UTHSCSA, for example, can be very helpful because those particular moisturizers, the urea in particular, is very, very hydrophilic, so it will attract moisture and bring it to it to help soften and lubricate the skin. And again, you'll commonly see these in areas where, especially in the elderly, where there's decreased oil gland production, particularly the extremities and the legs most notoriously. So that is, again, just a little bit on xerosis or erythema craquelle. In addition to applying appropriate emollients or topical moisturizers, keeping the patient well hydrated is going to be very important. One of the other things that happens in the aging population, as you probably are well aware, is that the sense of thirst actually decreases with age. The osmoreceptors don't work as well, and so sometimes elderly patients are much more prone to hydration because they don't always think to drink. And so we have to remind them that's very, very important. Even when you or I are kind of feeling thirsty, we're already partially dehydrated and our osmoreceptors are kicking in. So that's another important thing that's going to be very, very important. Seborrheic dermatitis. This is another problem that is, again, very common, not only in the elderly population, but also in the adult population. And I'm sure you've probably seen examples of that and thought maybe the patient just had a little bit of bad acne or maybe a little flare-up of something that was bothering them. But this is kind of your classic example of your seborrheic dermatitis. And what we're seeing here basically is, again, very commonly you'll see it in the nasolabial folds, between the eyebrows, the forehead, the eyebrows themselves, and sometimes along the hairline as well. And what you see is this redness. It's a flaking, scaling kind of a look. Almost looks like they need a moisturizer on their face or a real good acne product. And again, you'll also see this in other areas too as well, the chest, the scalp, and also on the back. And this is commonly due to, let me go back here. This is commonly due to a specific form of yeast to which some patients tend to be very susceptible. Not everyone in the population is susceptible to this particular yeast strain, but for some people this yeast, again, it colonizes the face, and again it has a particular affinity to the areas where we produce sebum. Again, the face, the chest, the back, and so on. And so what happens is these little yeast come in, and they find that in some people they have just the perfect environment for this type of infection, and so they end up with this, basically this long-term chronic type of condition, and it's directly a result of a yeast infection, something we wouldn't normally think about, but that's exactly what seborrheic dermatitis is. Now, a lot of times you'll see physicians will prescribe, or PAs or clinicians will prescribe a topical steroid. And the topical steroids generally will work short term, but it always comes back. And so the treatment of choice is really a topical antifungal. So ketoconazole, oxyconazole, any of the different types of antifungals can be very effective for treatment on the face. If there is an excessive amount of inflammation, you can also apply a steroid, but again, the treatment of choice should be some type of an antifungal. And for patients who have it in the scalp area, you want to, again, put some Nizoral or any type of a shampoo that has the antifungal property to it. And this is just, again, showing you another example. This is a little bit more subtle, but again, you can see these little changes, the redness, the scaling. The surface of the skin is going to be kind of dry and flaky and a little bit rough looking. So that's basically your, and again, something you'll see very, very commonly, particularly in the aging population. If you have any questions as we go along, please feel free to just interject and raise your hands or make a comment if you would like to. This is something I usually like to have is very informal as we proceed. So another thing that we will often see, and this is something where, again, as a nurse practitioner and as a wound care person, nurses will call my attention to these things, and they get really concerned thinking, well, gosh, do we have some kind of a malignancy going on here? And the answer is that not at all. This is Seborrheic Keratoses. These are extremely common findings in our patients, especially as they get older. And what they generally look like, they can be fairly large in size, up to 2 centimeters or so. And what they look like are these kind of thick brown, hypertrophied blobs, if you will, these little waxy looking structures. They almost look like you could kind of pick them off or pull them off. Which you don't really want to do because you can traumatize the patient. And these are basically, again, it's a hyperplasia of the skin cells. You commonly will see these in areas along the face. The back is very common, and also in women you'll see them under the breasts. They tend to want to form in what we call intertriginous areas where you've got skin on skin contact, and you'll see these. You can see these really in almost any area of the body. Dermatologist that I was spending some time with at one point, he refers to these as the barnacles of old age. And they're really harmless, they're benign, and there's really not a lot you can do about them. You can remove them using cryotherapy. They will often return. But if you see these again, it's just a good reminder of the fact that this is something that is fairly common that you will see in some patients. And again, as I mentioned, they're really a cosmetic issue more than anything else. Now, in a situation like this where perhaps you've got, and these are some forming seborrheic keratoses. This is kind of a nice big barnacle right here, if you will. In some situations, if it's interfering with, maybe a patient's bra line or clothing or something like that, then it certainly might be an indication to go ahead and try to remove it. But in general, most dermatologists or most wound care people will suggest that, just kind of keep an eye on it, monitor those areas, and if there's any change in them, certainly you want to bring that to the attention of a dermatologist. But for the most part, those are barnacles of old age that we don't really do a whole lot about. Now, another type of area where we will, again, commonly see skin issues with our elderly population are with what we call the dermatophyte infections, also, lovingly referred to as fungus amongus and yeasty beasties. And when we talk about fungus, that's kind of a broad term that includes both yeast and spores. And we see these most commonly in our high-risk patients, our patients who are diabetic, and of course we know in San Antonio, diabetes is not a problem, right? We see it on patients who have been on multiple antibiotics where the normal body flora has been suppressed, and then it becomes a perfect environment for opportunistic infections like yeast and fungus to come in and set up shop and have wild orgies and proliferate. And as I mentioned, this is another area where we see very commonly in the intertriginous areas, the skin-on-skin areas, the groin areas, under the breasts, the axillary areas. If you have a larger patient who has a little bit of extra skin, you might see it in the, the abdominal folds or underneath the belly. Very, very common areas, and of course also on the feet. And the dermatophyte infections in general, as maybe aesthetically unappealing as they are generally very easy to treat, most of which will respond to topical treatment, with the exception of fungal infections of the nail that need to be treated with oral antibiotics. So if we look at these, this is just an example of what we call Candida, a very common type of yeast infection that we see in patients. And typically with this particular situation, what we see is a macular confluent rash. So what we see is kind of a flat area of erythema, and then we see that out on the edges there are these little tiny satellites, if you will. And this is just a perfect example of your classic yeast infection. And these are often pruritic. These patients will tell you that they can be very irritating, very itchy. And as I mentioned, these are often associated with recurrent antibiotic use. Diabetics, immunocompromised patients are high risk. Patients who maybe their hygiene is not the best in the world and they end up with some sweat and moisture accumulation, they may also be prone to the development. And again, the treatment of choice, typically if it's a widespread yeast infection, you know, if the patient has it in multiple areas of the body, then perhaps an oral treatment with fluconazole might be indicated. But generally, these will pretty well respond to, you know, 14 to 21 days of BID topical treatments. Lotrimin would be a good example of something that you might want to use. And then this is showing you just, and again, just a very severe case of Candida. And again, I've seen situations, particularly in some of my obese clients, where there's just such an excessive amount of infection that the skin is actually eroded and denuded. And so these become exquisitely tender, they ooze, they're very, very painful. And so again, if you can jump on that kind of a situation before it gets to that point, you're really in an ideal setting. And of course, speaking of yeast, I just had to throw this in. It's a Pillsbury Doughboy. And so the other type of the dermatophyte infection that you'll commonly see is the tinea. Again, this is tinea, also known as athlete's feet, jock itch, crotch rot. This is a very common type of infection. You'll see it often on the feet, the heels. Patients that have ostomies, you'll see it around their stomas. And what you'll classically see with these particular types of infection is you'll see scaling, you'll see, you'll see scaling, you'll see redness, you'll see just a lot of irritation. And in this particular case, we also have some toenail involvement as well. And when you get the tinea, and this is typically associated with excessive moisture contact, and if there's any damage to the nail plate, you'll also get an infection in the nail, and that's referred to as onychomycosis. Very common finding in the feet of elderly patients. And so for patients who have tinea confined to the skin only, it will really respond quite nicely to topical antifungals, just as you would with the yeast infections. Looking at these types of patients, again, BID or twice-a-day treatment with Naftin or other type of antifungal will work very, very well. Now, if the patient does have the onychomycosis, in other words, you've got the involvement of the nail bed itself, this will not respond to treatment, and so therefore those patients will generally need about 12 weeks of oral antifungal treatment in order to completely cure that. And in that case, those patients might go on Lamisil, which is a very commonly prescribed agent, or Sporanox. In some cases, if a patient has just a simple involvement of a single nail, then sometimes a Penlac can be used, which is basically a product that's actually painted on the nail plate. But again, and this is something too where, you know, if you see a lot of this, it's not necessarily just dry skin. So you really need to, you know, bring it to someone's attention, or, you know, look at how you can maybe affect treatment for that patient. And then this is just showing you just the extreme example. And of course, being that I do, you know, currently practice quite a bit in long-term care and home care, unfortunately, this is not very uncommon. This is a very severe case, of course, of onychomycosis with a lot of deformity. Easily treated with a good podiatrist who can go in there and debride that out. But, you know, unfortunately, you will see this. And again, a lot of times if you see someone who is, you know, this involved, you might want to think, well, what else is not being taken care of either? So just something to keep in mind. And the actinic keratoses, this is something that you will also see very commonly, especially down here, you know, in the sun-loving South. People are always out and about, engaged in outdoor activities. And one of the things that we see, especially among a lot of our older retired military that get out and they're out in the golf courts or out fishing or out spending time, is we see a lot of what are called actinic keratoses. And what you'll typically see is basically it looks like the patient has a very uneven complexion. You'll see scaling, redness, telangiectasias, which are little fine dilated capillaries in the face. And again, you'll often see these in areas that are prone to sun exposure, the top of the head, the ears, the face, the arms in particular. And when you see these and you look at the patient, these are generally fairly small lesions. They're usually, you know, a couple of millimeters, maybe 2, 3, 4 millimeters in size, and they have lots of them. And when you put your hand, if you gently rub your hand over the surface where you see these, it'll feel kind of rough like sandpaper. And in some cases, they might even say that these feel kind of sore or tender. And when you see these, it's something that you really don't want to ignore. And again, ideally would want to refer this to someone like a dermatologist or wound care expert for proper treatment, because with actinic keratoses, these are considered pre-malignant, and approximately 1 to 2 out of every 1,000 lesions can actually revert to skin cancer. So again, when you see this, it's very, very important to go ahead and bring these to the attention of someone who, again, will address these properly. The treatment options for these typically, and again, we can see another couple of examples here of, again, these fine little scales that, again, are raised above the skin. And this is another example, again, especially in patients who have male pattern baldness, you want to look at the top of their heads as well, because that can be a common location for these problems. Treatment generally involves, again, in the dermatology clinic, they can do cryotherapy, liquid nitrogen, just kind of blast away that area, and then that area will actually form a little crust and scab over and heal in about 2 weeks. If there's a lesion that's particularly suspicious, it should be biopsied. And then the other treatment is Fudex, and there's some other variations on the market, but it's basically a topical chemotherapeutic agent. It's 5-FU that's applied topically twice a day for about 3 to 4 weeks, and that will also take care of the problem. And then, of course, you want to, of course, aggressively counsel these patients regarding sun protection. You want to make sure that they use, you know, an SPF of at least 30, ideally more is better, with either a titanium or zinc oxide, which is an actual mechanical barrier, or the Parcel 1789, which is a chemical barrier that's extremely effective. And again, no matter what people's age or skin color is, sun protection is really, really critical. So that's a couple of examples of, again, common findings that you'll see with these patients. Now, as far as skin malignancies, there are a number of different ones out there. We're going to talk about the most common ones that you're likely to see, which would include your basal cell carcinoma, your squamous cell, and your malignant melanoma. Now, your basal cell is actually the most common. It accounts for about 70 to 80% of most skin malignancies. So if you see this, it's fairly classic looking in appearance. And if you see this, you again want to certainly bring it to the attention of the patient or the care provider. And typically what you see with these is these will be kind of an elevated, almost warty looking, if you will, verrucous plaque that you'll see again commonly over sun-exposed areas. The scalp, the nose is a very common area, the ears, the face, arms. It may or may not have an ulceration. These patients may even tell you they tried to pick it off thinking it's a wart and it came back even bigger. And although they are common on sun-exposed areas, you can also find them in other parts of the body. I had a 102-year-old patient that I was treating recently who actually had one on her underneath area, not in the armpit, but near it. And we biopsied it, and lo and behold, it was a basal cell. So again, if you see something like that, if you're not familiar, you know, you want to try to certainly address it. The rule of thumb is really better safe than sorry. And this is showing you another couple of examples. You wouldn't normally expect to see a basal cell on the sole of the foot, but it certainly is a possibility. And again, very commonly on the nose, you'll see again, it's kind of waxy, lobular looking lesion that sticks up, it projects above the skin. And these can be fairly large in size. They can be, you know, a couple of centimeters even. So again, if you see these, beware. And then you have the squamous cell, which is another type of lesion. Not quite as common, but certainly a prevalent type of skin malignancy that you should be aware of. And these are a lesion that you will actually see anywhere in a variety of areas. And again, those of you who especially are involved in doing mouth care, that's not an uncommon area, is to find these on the tongue, on the buccal surface of the mouth, on the face. These can also be found, again, in a variety of areas, the genital areas as well. And typically the squamous cell lesions that are found within the oral mucosa or the genitalia tend to have a higher association of metastasis and can be particularly challenging to deal with. And what we often see with the squamous cells, especially if they're really ignored over time, is we see this large non-healing type of sore. Doesn't seem to be getting better no matter what you're doing. And this is just another couple of examples that you'll see, this large protuberant, and again, this is something that's been ignored for a very long time. Again, very, very suspicious, something that you certainly want to do something about. And in my practice, one of the things that I see, you know, unfortunately from time to time is I'll have a patient, this is showing you a patient who's got a venous leg ulcer. This is their ankle and their foot down here. And you can see this large area, it's very irregular in shape. And at first glance, you would think, well, that's a venous stasis ulcer, which is another type of common wound issue that we see, especially in middle-aged to older adults. But what happens, what should be a flag is if you're doing wound care and you know that it's an appropriate wound care and you're managing all of the aspects related to good wound care, and the wound is still not progressing or in some cases is getting worse, then that would be certainly an indication that you might want to biopsy it. So again, anytime you see these types of issues, you're really better safe than sorry. And again, the treatment for your basal cell, kind of skipped over, that would basically be, of course, excision and biopsy of the lesion, and the same, of course, for the squamous cell. Melanoma, probably the most insidious and most potentially lethal of all the skin malignancies. And this is something that can unfortunately be often mistaken for a hairy nevus or a wart or a mole or something that is fairly common. And the melanoma is often described in terms of what's called A, B, C, and D. When we talk about a patient who has a melanoma, we think about A being asymmetry, that these generally are very non-symmetrical, irregular shaped lesions. We look at the border and we find that usually there's an elevated border and that these often will have a very funny looking color. They may be anything from a dark brown to a purple. We look at, again, the color, as I mentioned, which can be very, very dark, and then the diameter. And the diameter of more than 6 millimeters is considered suspicious and should be evaluated. And again, this is just showing you another example. Again, we see this very asymmetrical, darkly pigmented lesion. Again, it can be black, purple, bluish looking. The significant thing about these two is if you see these, depending on how deep or how thick they are, is going to be a determinant of the prognosis for cure. And generally, if these lesions are less than 0.76 millimeters in depth, then the cure rate is approximately 90. I think it's 93%. So the earlier these are identified, the better the prognosis for the patient. And again, melanomas can arise in persons of all colors. And so if you see something that's a deeply pigmented lesion, that's asymmetrical, that's got these strange looking borders, and especially if it's larger than 6 millimeters, and looks like it may be changing over time, or the patient reports to you that it's changed over time, you definitely want to address that. And that will typically involve usually some aggressive surgical excision and probably chemotherapy depending on the patient. So that's a little bit of an overview of some of the common skin tears. So again, the idea being that, you know, as you look at patients and you're assessing them, is just looking at their skin and looking what's on their skin and looking at the different things that you see on their skin and trying to think about whether or not that's normal or abnormal, and I'm not really sure, so maybe I'll have somebody else look at it. Just again, trying to heighten your awareness, because I think it's really important. Now, as I mentioned, skin tears are very common among the elderly population for the reasons I talked about before. You get that loss of the epidermal-dermal junction. You get, again, over time, especially in the extremities, there's atrophy of the subcutaneous tissue, so there's not as much padding between the skin and the underlying bony prominences. Patients who have a history of steroid use, their skin is going to be very friable. They're going to have pre-existing purpura or little areas of bruising that are going to be more susceptible to trauma. Patients who are on anticoagulants. So all of these, which is, again, these are all very common findings in the elderly, especially if you have someone who has multiple comorbidities, which is very common, they're going to be very susceptible to the development of these skin tears. And what's particularly problematic is that when these skin tears develop, if they're not properly treated, they can go on to become infected. You can get, you know, a secondary cellulitis, and it can become very severe. So early intervention is going to be very important with these folks. And ideally, when these occur, especially if it's a new or an acute onset, if there's a flap intact, in other words, the patient's just basically been moved from their bed to the wheelchair, and in the process they bump their arm on the nightstand, and lo and behold, they've got this big flap of skin hanging down. Ideally, what you want to do is, again, clean that area very thoroughly. You want to reappropriate or reapproximate that flap, and you want to go ahead and steri-strip it if you happen to have those available. And then there's certainly a little bit of debate about adherent versus non-adherent dressings. And ideally, the appropriate choice is basically to use a protective dressing that's going to absorb drainage. Some of the different options out there are hydrofiber, which is basically an absorbent type of dressing, and a thin hydrocolloid or duoderm. Sheet hydrogel, which is kind of a viscous gel-like type of protective dressing. Adaptic, which is basically like a Vaseline impregnated non-adherent dressing. Cellulose, which is another type of absorbent non-adherent dressing, or visco paste, which is basically kind of a gauze material that's impregnated with some non-adherent ingredients. So there's a variety of options, and again, you know, the purpose here is not to make you wound care experts, and certainly if you have questions afterwards, I'd be happy to address those with you. But the idea being really that you just want to make sure that those are properly attended to. And again, you know, not only do you see these in long-term care, but you can have your patient that is, you know, in the clinic, and they transfer from the wheelchair into their examination chair, and lo and behold, boom, they've got a skin tear. What do you do about it? So these are things that you're likely to see despite your practice settings. And then finally, last but not least, is the issue of pressure ulcers, which unfortunately is an all too common problem that we see, especially in our elderly. And, you know, I think most people tend to think about pressure ulcers being something that occurs in the long-term care environment. Well, that's the nursing home. I'm not going to worry about it. I don't go there. That's the hospital. I don't work there. But you know, increasingly more and more, we also have patients in the community that are being treated at home for pressure ulcers. So they may come in, especially if they also have concurrent spinal cord injury history or history of stroke or other types of problems that leave them immobile or otherwise impaired. They may also have issues. And so again, it's important to be aware of those so that you're, again, familiar with the care that they require. Some of the risk factors that you'll see with pressure ulcers, clearly malnutrition is one of the biggest problems. And nutrition, especially in the elderly population, is something that should be of primary importance to all of us, because without proper nutrition, the elderly are really at high risk for a whole host of problems. And in particular, with respect to skin damage or pressure ulcers, if they are not eating well, they're more likely to develop a pressure ulcer or skin care problem. And once they have that problem already in place, they're going to have real challenges in terms of healing, because the body needs adequate amounts of protein and calories, fat, in order to create those building blocks to create new tissue for healing to take place. Patients who have a history of immobility, as I mentioned, you know, your stroke patient, your patient who's just no longer able to walk well anymore because they've got severe osteoarthritis of both hips and they can't get up out of their wheelchair. Patients who, again, have a history of spinal cord injury, any variety of problems, neuromuscular, multiple sclerosis, things like that can all be contributing factors. And their overall condition, you know, the patient that's got high blood pressure, peripheral vascular disease, diabetes, and hyperthyroidism is going to also be at more risk for the development of problems. It's kind of an unfortunate balancing of the scales against healing for many of these folks. And again, as far as ulcers, I think that this is probably something that is important to point out as well. Nosocomial ulcers, those are the ulcers that we usually give free with any hospital or long-term care stay. And those we see about 20% occur in hospitalized seniors and in 5 to 12% of the long-term care residents. And unfortunately, the rap is that it's the nursing home's fault. And the nursing home and the hospital are always going, it's their fault, we didn't do it, you know. And of course, the plaintiff's attorneys just eat that up. But it is a common problem. And again, most commonly, you'll see it in the hospital and long-term care setting. But again, you may have home care patients as well that have this. And of course, as you can appreciate, it's got significant implications in terms of complications, costs, and legal issues. So just a little bit about the pathology. You know, most of the time, you know, when we think about pressure, it's kind of like, well, duh, pressure causes pressure ulcers. Well, yes, it does. But the specific dynamics, I think, are important to keep in mind. Typically, what will happen with the development of a pressure ulcer is it's the direct result of compression of the tissues between two hard surfaces. And typically, this tends to involve a bony prominence, the hip, the sacrum, any number of areas which we'll get to, and a hard surface like an unforgiving mattress or a hard wheelchair. Something like that, again, is very, very important. So what happens is you get the compression of the soft tissues. And once that pressure reaches the magic number of 32 millimeters of mercury, which is actually a very low number if you think about it, once that 32 millimeters of mercury pressure is reached, the capillaries are literally, they collapse upon themselves. And so you get an area that is no longer getting blood flow. And of course, over time, as the tissues are deprived of oxygen and nutrients, the cells die, and you get cell death and necrosis. And so that's really the whole essence of how a pressure ulcer forms. And what we're particularly seeing here is, you know, a lot of times muscle tissue is more susceptible to the effects of ischemia than the skin. And so a lot of times you can actually have a wound that's much deeper at the bottom than it is at the top. Have any of you ever seen that or experienced that? I see a few heads, yes. Been there, done that. And so a lot of times when you're looking at these wounds, you know, it may be a centimeter at the surface, but it may be 3 or 4 centimeters below because of the nature in which these types of injuries form. And this is just showing you again the kind of a damage or crater that we'll see. And again, this tissue has been compressed between, again, the outside world, some kind of a hard surface, and a bony prominence. And so this ischemia has caused cell death and necrosis. And many times, because, as I mentioned, the muscle is more susceptible, you may see a wound that's bigger at the base than it is at the top. And a lot of times we'll call that the tip of the iceberg. And when you see the tip of the iceberg, it's important to be aware that there's a lot more to it than meets the eye. And we've talked about this already. Again, and you'll also hear the term cone of damage, where again, you'll see this wound that at the surface might be smaller than it is at the bottom. And these are your typical stage 3 and stage 4 pressure ulcers. Common pressure points, as I mentioned, again, will depend on the position of the patient. The most common location for the development of a pressure ulcer is the sacrum. Other very common areas are the trochanters or hips, the heels. And one of the problems with the heels is that the heel is probably, even in a healthy adult, is one of the most poorly perfused areas of the body. And so you have someone who not only has now this pressure damage, but they happen to be diabetic and they happen to have peripheral vascular disease. You've got a real challenge on your hands in terms of healing. So these are just some things to think about. The other areas that are very common for the development of pressure ulcers is something we see very often in our patients who are spinal cord injury patients that are up in their wheelchairs all over the place. You know, they're tooling around in their little motorized wheelchairs going here and there. Well, if they're not taking proper precautions, they will actually develop pressure ulcers over the ischial prominences or ischial tuberosities. And so that also, for patients who sit for prolonged periods of time, this arrow is not really letting me show you that, but those sits bones are going to be other areas where they're likely to develop pressure ulcers and significant damage. So when we look at pressure ulcers, again, I'm sure a lot of you have heard of the staging system, and that basically is a way to describe the level of anatomical damage or depth that you're looking at when you're trying to describe and quantify these wounds. And they basically go from stage 1 to stage 4, with stage 1 indicating the least amount of damage, all the way to stage 4, which really involves the most extensive amount of tissue damage and tissue loss. So just briefly, because I know it's getting late, your stage 1 is basically the non-blanchable redness of intact skin. And this is where, again, your patient may say, well, you know, oh, my butt's kind of sore, and, you know, they reposition and you look and you see this area of redness, and you depress it with your fingers and you find that it doesn't blanch, it doesn't turn white when you do that, and it doesn't go away after you relieve the pressure. That's your stage 1 pressure ulcer. One of the things that's also important to realize is, again, the epidermis is not open. There's no open areas, but it's this dark discolored area. And in a darker colored patient, it may also be represented as purple looking or hyperpigmented. And when you touch it, if there's warmth or induration, those are all indications as well that you may potentially have a pressure ulcer. So again, very, very important to take steps immediately to relieve that pressure and keep that patient off of that area. One of the big problems with a stage 1 ulcer is that in many cases they may go on to rapidly develop into stage 3 or stage 4 pressure ulcers. And it's for exactly that reason I discussed before, because you get that localized pressure, the muscle is much more susceptible to ischemia, so the damage occurs from the inside out. So you could have a stage 1 pressure ulcer on a Monday and a stage 4 on a Friday. And then your stage 2 is basically partial thickness breakdown. And this is where now the skin is open, but you haven't gone all the way through the dermis. And typically what these will look like is very superficial open areas, real pretty too, huh? Good postprandial pictures for you. And these basically will look like superficial breakdown. They might look like a deroofed blister or a shallow crater. There's no real appreciable depth. And typically with stage 2 pressure ulcers, with appropriate treatment, you can often get these to heal within 2 to 3 weeks, if, again, you provide appropriate treatment or refer the patient appropriately. Now your stage 3 really involves much more extensive tissue damage, and this is where now the big difference is that you've gone all the way through those epidermal and dermal layers that we talked about in that first slide, and we showed you that cross-section, and now you're into subcutaneous tissue. And in this case, the tissue damage may become as extensive as going all the way down to, but not through the fascia level. And the fascia, as you recall, is that protective sheath over the musculature. So the main difference between a stage 3 and a stage 4 is that with a stage 4, now you've gone all the way down to actually the level of muscle, bone, joints, joint tendons, capsules. And you have significant and extensive tissue loss associated with these types of patients. And this is a patient of mine who, again, had a full thickness pressure ulcer. If I can find the arrow here. There we go. And you can see this is actually the sacral prominence jutting out through the tissues. So again, significant high risk for osteomyelitis when you see this type of breakdown. Some of the basic limits of the staging system, you really only want to use it for staging pressure ulcers. And it's not appropriate to stage a dehisced surgical wound or a venous ulcer or an arterial ulcer, and I've seen this done a lot, but you don't want to do it. And a stage 1 ulcer, as I mentioned, may actually really be representative of much more serious tissue damage, especially if there's a lot of induration and warmth at the site, so be leery. And the other thing, of course, is that if a wound has necrotic tissue in it, if you can't visualize the base of the wound, it's not considered a stageable ulcer, and it's perfectly appropriate to document wound or pressure ulcer is unstageable due to the presence of eschar, which again is your classic dark brown, black leathery covering, or slough, or if you're not sure what you're looking at, devitalized tissue. Basically in these wounds, if it ain't red, it's dead. So you can, to be on the safe side, just call it necrotic or devitalized and you'll be perfectly safe. So as far as management, again, wound care is very, very important, and again, it's kind of beyond the scope today to go into a lot of detail, but you want to debride the wound. Those wounds I just showed you with the necrotic tissue, that's got to come out of there. So those wounds need to be debrided, and there's a variety of ways to do that. They need to be cleaned and properly dressed. The patient, the host, has to be managed. So if they're diabetic, you control their diabetes. If they're malnourished, you need to feed them. If they have peripheral vascular disease, you may need to look at revascularization or pharmacotherapy to help increase their perfusion. Again, circulation is important. If there's a lot of edema or swelling, particularly in the distal extremities, that's going to be important for you to decrease that edema. Because that edema will interfere with the diffusion of oxygen and nutrients out to the tissues to heal the wound. Nutrition, I could spend 8 hours talking about how important nutrition is in wound care. An aggressive approach is really, really important with these folks. And then multivitamins that are very important in helping with some of the different coenzymatic reactions, and then providing some of the substrates for tissue healing are going to be important. And particularly, you'll see patients who have ulcers or various wounds, usually on multivitamins, vitamin C, zinc, and beta-carotene, as well as in some cases vitamin E. You also want to aggressively assess for and treat infection, because infection delays wound healing and can again go on to become systemic if not addressed. Correct or contained continence, again, the sacral area, the coccygeal area are areas that are prone to contamination with urine or feces, so that needs to be addressed. You want to reduce pressure, friction, and shear. And again, if many of these patients are, despite the setting, might need to be put on what we call an appropriate support surface, and there's a variety of them out there. But ideally, this is showing you a very good example of what we would call a low air loss mattress, which again helps to decrease the pressure on that tissue interface to again help offload pressure and promote healing. And so in general, I just gave you a very, very fast and furious Reader's Digest overview of derm and wound care issues in the geriatric population. And I really appreciate the fact that during this whole period I didn't see any O or Q signs. Do you know what those are? It's when at the end of the day, you're kind of inundated with all this information from all these speakers, and you're kind of tired, and you've had a few snacks, so your sugar level kind of does this and then it does that, and all of a sudden your eyelids start getting heavy and you start getting real tired, and the head tips back and the mouth gapes open. That's the O sign. And then if you get if you go to the step beyond that, you get to the Q sign, and that's where the tongue starts hanging out. And I was really pleased too, because I didn't see any cases of auditorium whiplash. Do you know what that is?
Oh yeah.
I think we've all been guilty of that at some point or another. But again, this was kind of some dry material for the end of the day. Certainly would be happy to answer any questions you might have. Yes, ma'am.
That wasn't dry. That was really excellent, and thank you. And I actually do have a question. There are lots of families who have a family member with an ulcer, even if it's one that's resolving, and they need to do home care. You can't walk into the Walmart or the Target and buy Visco gel. I mean, these things, and physicians don't prescribe them for the families. There's a tremendous lack of communication to help these people get over their problems when they're homebound. And what do you predict, given the fact that we're going to have more and more elderly being cared for at home? Are we going to see a change? Are we going to see a change in that?
I think that's an excellent observation, and I think it's going to be a situation that will probably become of crisis proportion before we take any initiative to do something about it. Absolutely, because what we're seeing is, patients they're in the long-term care settings for shorter periods of time. They're being turfed into the SNF settings, and then from there they go home, and not necessarily always with everything that they need for proper care. And then the home care agencies have been really limited in what they can offer the beneficiaries, particularly the Medicare beneficiaries, because they have caps as well. And so they really try to spread out their visits, and there's only so much they can do. And I think it's going to end up becoming a significant problem before finally someone steps up to the plate and says, look, we need to address this more aggressively.